The Enpc and TNCC criteria differ slightly, but the prioritization sequence for assessment and intervention is the same. If you receive pre-hospital notification about the patient, you have a few minutes to activate the team, prepare the room and any equipment, and don PPE. The across-the-room observation provides a general impression of the patient's condition. Is there any need to reprioritize to C, ABC because of uncontrolled hemorrhage or a need for chest compressions? In the pediatric patient, you will use the pediatric assessment triangle to determine if the child is sick, sicker, or sickest. If you did not receive pre-notification of the patient's arrival, you will activate the team, assess for safety risks, and don PPE before performing interventions. Alertness and airway, breathing and ventilation, circulation and control of hemorrhage, disability, and exposure and environmental control are the A, B, C, D, E of the primary survey. Listed on the screen are the assessment criteria for each letter. Each letter must be assessed in order, making them double-starred steps of the pediatric or trauma nursing process. Performing these steps out of order can easily result in missing a life-threatening condition. If any abnormalities are noted, the learner must immediately intervene and reassess prior to moving on to the next letter. Interventions may include, but are not limited to, insertion of an airway, bag mask ventilation, intravenous fluid or blood administration, assessment of a blood glucose, and controlling any external hemorrhage. We do appreciate that in real life, these assessments take seconds and interventions may occur simultaneously with multiple team members present. It is, however, feasible that there may come a time when you are the only person available to manage the initial assessment. More importantly, breaking the process down into very specific assessment criteria and interventions, which must be stated and performed in order, is a proven teaching learning strategy to make the process second nature for you when managing a real patient. F and G are considered adjuncts to the primary survey. In F, you will facilitate family presence and obtain a full set of vital signs. In G, you will obtain labs, attach a cardiac monitor to the patient, consider the need for a naso or orogastric tube, assess and manage oxygenation and ventilation, and address pain. Addressing pain includes an assessment using an appropriate pain scale and managing pain with non-pharmacologic and pharmacologic measures as needed. Pain assessment is considered a single-starred step. This must be done before the completion of the scenario, but can be done at any time. Sequence is not vital. The secondary survey is designed to identify all injuries or indications of illness. This is accomplished with a thorough history and head-to-toe exam. Critical findings can be missed if this exam does not include the back, so inspecting the posterior is an important reminder. If the patient is still on any sort of a transfer device or longboard, it should be removed at this time. Before log rolling the patient, consider the possibility of a spine or pelvic injury based on the patient assessment. It may be safest to obtain imaging first or use alternate techniques to move the patient, as log rolling may worsen cord injury in the unstable spine or cause hemorrhage in the unstable pelvis. The nurse will now anticipate interventions or diagnostics based on the patient scenario. At this point, the team has likely left the patient's bedside. It is the nurse's responsibility to just keep reevaluating. The nurse will communicate any concerns with the team and intervene as appropriate to changes in the patient's condition. Can you see how this systematic process will help you turn chaos into order and prioritize when you have a very sick patient in front of you? Don't worry if it doesn't. Just keep studying your provider manual and your instructors will help you apply it in class. 6 teaching scenarios will be used in class to reinforce this systematic assessment process. We will now show you an example of what this looks like in real time. Follow along with your pediatric or trauma nursing process reference.
Here's your triage report. A caregiver of a 4-year-old female states her daughter has had an odd cough and seems to be breathing faster than usual. She was just at a friend's birthday party, and the caregiver drove her straight to the emergency department from the party. Please begin your initial assessment process.
Okay, so I would like to do my across the room observation. I want to look to see if there is any uncontrolled hemorrhage or if there's unresponsiveness or apnea. Is there any need to consider reprioritizing to see ABC?
There is no need to consider reprioritizing to see ABC.
All right, so then I want to look at my pediatric assessment triangle. So I want to look at her general appearance, her work of breathing, and circulation to the skin.
She's sitting straight up. She's not really looking at anything around her. She has very fast and shallow respirations. Stridor and expiratory wheezes are audible, and her face is flushed.
Okay, so she is sickest. She's got alterations in all three, so she definitely needs to come right back to a resuscitation room.
Is there any specific equipment that you would want in the room as you take her back?
I want to call my team. I want to make sure they have all the appropriate personal protective equipment on. I want to hopefully have a bed scale, something that we can get a weight, or we'll use a length-based resuscitation tape. I want to have pediatric-sized airway equipment, and I would like to have respiratory if we have them available standing by, and I would also like to get some intramuscular epinephrine ready for this girl.
Your team is at the bedside. All of their PPE has been donned, and the room is ready.
All right, so I first want to assess her level of alertness. Is she alert, or is she somewhat, does she respond only to verbal, only to painful stimuli, or is she unresponsive?
She's alert, but she's very focused on her breathing, and she answers questions with just one-word answers.
All right, so that is not normal. I'm going to let her assume whatever position she can to keep her airway open. And I am going to ask her if she can open her mouth so I can look in her airway. And when I do look in her airway, I'm going to be looking for any tongue obstruction, any loose or missing teeth, any foreign objects. Does she have any blood, vomit, or secretions? Is there any edema? And you already mentioned some stridor. Does she have any gurgling or snoring going along with that?
There's no tongue obstruction, no loose or missing teeth, no foreign objects, no blood, vomit, or secretions, but edema is noted around the lips. There's no snoring or gurgling, but the stridor, as we mentioned before, and no bony deformity.
All right, so I would really like the physician to order some intramuscular epinephrine. We will probably be preparing for intubation.
The child weighs 17 kilograms per the standing scale that you put her on in triage, so that would be 0.17 milligrams of intramuscular epinephrine that's been ordered, and we can administer that in the anterolateral thigh per the physician order. And your team is preparing for intubation.
Okay, so I'm going to reassess alertness and airway after she has gotten that intramuscular epinephrine.
She is now less responsive. Stridor and expiratory wheezes are less audible. The tongue is now edematous and obstructing the airway.
All right, so we're going down that intubation path. I want to put a towel underneath her shoulders or torso to help open her airway. I don't think an oral airway is going to work with her swollen tongue, so we can try a nasopharyngeal airway, and then I will assess her breathing after we do some airway maneuvers.
The child is now supine with the folded towel under her shoulders and torso. She has a nasopharyngeal airway in place because you're correct, an oral pharyngeal wouldn't fit with the edematous tongue. Your supplies are being gathered for intubation, and that IV catheter is being placed for drug-assisted intubation. Please proceed with your assessment.
Okay, So I want to look at her breathing. What is her general rate, depth, and pattern of respirations? Is she breathing spontaneously? Does she have equal chest rise and fall? What is her skin color like? I want to listen to breath sounds and looking for any increased work of breathing. She had some stridor. Is she grunting or having any retractions when we lift her shirt up? Any head bobbing or nasal flaring? Yeah.
Breathing is spontaneous but shallow and slow. Chest rise and fall is symmetrical. Respirations are shallow, irregular, and slow. No increased work of breathing is noted. Skin color is cyanotic. No open wounds or deformities are noted. Breath sounds are very diminished bilaterally. No sub-Q emphysema, no tracheal deviation, no jugular venous distension.
All right, she definitely needs bag mask ventilation, so I'm going to assist her with bag mask ventilations, and I'll assess, do I have chest rise and fall with ventilations, and do I have breath sounds, any improvement with skin color doing assisted ventilations.
Your chest rise is symmetrical with assisted ventilations. Breath sounds are very diminished with faint wheezes bilaterally. Skin color remains cyanotic. And the patient has just been intubated. Please demonstrate and describe your assessment of endotracheal tube placement.
All right, so I would like to place an end-tidal CO2 detector on. After 5 to 6 breaths, we're going to look for positive evidence of end-tidal CO2. We are going to watch her chest rise and fall. We are going to listen over the epigastrum for any gurgling and then listen over both lung fields. Do we have equal breath sounds bilaterally? And I'm hoping she's turning less cyanotic. Her skin color is improving.
Chest rise is symmetrical and adequate with assisted ventilations. No gurgling is auscultated over the epigastrum. Her breath sounds are very diminished with faint wheezes bilaterally. After 5 to 6 breaths, you do see positive evidence of end-tidal CO2, and her skin color has now improved to pale.
All right, so she's probably going to need more epinephrine, so we'll ask if the physician thinks it's long enough, or look at our recorder, has it been long enough for another dose of epinephrine? And we will definitely look at where that endotracheal tube is. We want to document where it is at the teeth and secure it, and then have somebody ventilate her at an appropriate rate.
Perfect. So that other intramuscular dose of epinephrine has been administered, and an epinephrine infusion is also being prepared per the physician orders. The endotracheal tube has been secured and placement has been documented with the number noted at the teeth. Ventilations are continued at an appropriate rate, and you may now continue with your assessment.
All right, so for circulation, I want to palpate a central pulse. I want to compare that to her peripheral pulse. I want to check her skin for color, temperature, moisture, and check her capillary refill time.
Central pulse is present and rapid. Peripheral pulses are weaker. Skin is pale, cool, and dry. Cap refill is 6 seconds.
Okay, so she has 1 IV from the drug-assisted intubation. We'll want to make sure that is good. We'll want to put in a second intravenous line, and she will need a fluid bolus. It will be 20 milliliters per kilo of warmed isotonic crystalloids, and we'll give that using that push-pull method so she gets it in quickly.
The IV line inserted for drug-assisted intubation is patent, and that second IV line has been inserted. A warmed isotonic crystalloid solution bolus of 340 mils is completed using the push-pull method.
All right, so I want to reassess her circulation. I'm going to, again, palpate a central pulse, compare it to her peripheral pulse. I want to assess her skin for color, temperature, and moisture. And I'm not expecting her capillary refill to return to normal, but I do want to assess it and see if maybe we need more fluids.
Her central pulse remains rapid. Peripheral pulses remain weak. Skin remains pale, cool, and dry. Cap refill is 4 seconds. Epinephrine is now being administered by continuous infusion and will be titrated per order.
Okay, so I am going to give her another fluid bolus. I think she needs this, another one. So we'll give her another 340 milliliters of warmed isotonic fluids. using the push-pull method. And after that is in, I'll reassess her circulation. Again, feeling for central pulses, comparing that to her peripheral pulses, feeling her skin color, temperature, and moisture, and cap refill. Again, not expecting the cap refill to normalize with the epinephrine infusion.
Good. A warmed isotonic crystalloid solution of 340 mils is now completed using the push-pull method. Your central pulse is now stronger and has slowed to a more normal rate. Peripheral pulses are now stronger. Skin is pale, warm, and dry. And I agree, her cap refill may not return to normal because of the epinephrine infusion.
Okay, so I think I'm okay to go on to disability now. We'll keep an eye on ABC. I want to look at her pupils. Are they equal, round, and react to light? And then I also would normally get a Glasgow Coma score, but she's sedated and paralyzed, so she's non-testable for Glasgow Coma score, so I will get a 4 score for her to assess disability.
Pupils are 4 millimeters, equal, round, and reactive to light. Your GCS we will document as untestable because she has been intubated. For your 4 score, you find that her eyelids remain closed with painful stimulus, which is a 0. There is no motor response, which is a 0. Her pupil reflexes are present. Corneal reflexes are absent, which is a 4. And she's breathing at the ventilator rate, so that's a 0. Your total 4 score is 4.
All right. I do want to check a blood glucose because she was getting a little bit altered before we intubated her.
Yeah, she was. The glucose is 35 milligrams per deciliter or 1.9 millimoles per liter.
All right, so we will need to get an order to give her some intravenous dextrose. We will reassess that. In the meantime, we're going to remove all of her clothing. We're going to inspect her quickly, just making sure we're not missing anything else life-threatening before we cover her up with a blanket. And we'd be giving her warm fluids. We want to make sure we keep her warm.
The intravenous glucose was administered. The facial flushing and edema that we saw earlier is now improving. There's no other obvious signs of illness or injury. And your warming method has been applied. You said you would use a blanket.
Okay. It's now time to get a full set of vital signs. So we'll get a full set of vital signs, including a temperature, and go from there.
Okay. Blood pressure is 100/84. Heart rate is 132 beats per minute. Assisted at an appropriate respiratory rate on the ventilator. Her temperature is 36.4 degrees Celsius or 97.6 degrees Fahrenheit temporally, and her weight has been confirmed at 17 kgs.
All right, so we want to make sure her family is brought back if they are okay with it. We want to have a liaison to let them know what's going on and to give them support.
Caregivers are at the bedside and the charge nurse has been assigned as a liaison.
All right, so I want to get my adjuncts and give comfort. So we want to, if we haven't already, we would get our labs, including a repeat glucose. She'll need a lactate for sure. Glucose and lactate are probably the priorities. We want to get her hooked up to a cardiac monitor. We're going to put in a gastric tube to decompress her stomach with the endotracheal tube in. I do want to attach her to both pulse oximetry and end-tidal capnography, and we'll consider titrating her oxygen to make sure that she doesn't get hyperoxic or hypoxic. We're also going to use a age-appropriate and now a nonverbal pain scale because of her sedation. And if we do identify pain, we'll need to get an order for some pharmacologic pain management and also give her some non-pharmacologic pain management. Her parents can talk to her, give her a stuffed animal, do something to comfort her to help reduce her pain or reduce her discomfort.
Your blood samples have been sent to the laboratory and the bedside glucose is now 86 milligrams per deciliter or 4.8 millimoles per liter. The cardiac monitor shows sinus tachycardia without ectopy. Your orogastric tube has been inserted. Her SpO2 is 96% and her end-tidal CO2 is 42 millimeters of mercury with a normal waveform. Oxygen is being titrated appropriately to avoid hyperoxia. Your pain is assessed at a 2 using the revised FLAC pain scale. So your non-pharmacologic interventions have been instituted, and then an appropriate dose of sedation has been ordered and is now being titrated. At this time, is there a need to consider admission or transfer to a pediatric facility or preparation for surgery?
Yes, she will need a pediatric ICU, which we do not have at my facility, so we're going to need to start facilitating a transfer.
Great, we'll get that started for you.
Okay, so we'll move on to our secondary survey, doing our history. So we will ask the family for the sample history. So what were the signs and symptoms? Does she have any allergies? What medications is she on? Any past medical history? Are her immunizations up to date? When did she last have anything to eat or drink, if they know when she last urinated? And are there any other events that we don't know of that led to her coming to the emergency department?
Her family provides the sample history. Signs and symptoms are that there was a change in her breathing and coughing after attending a friend's party. She has no allergies, she takes no medications, she has no past medical history, and her immunizations are up to date. Her last oral intake was at the party, and mother is unsure when she voided last. And again, there was nothing unusual until after the party when the coughing began.
Okay, so I think I'm ready to do my head to toe assessment. So I'm going to inspect and palpate. So we will start with her head and face. I'm going to inspect and palpate her face.
Endotracheal tube and orogastric tube are secured. Oral mucous membranes are pink and moist. Facial edema and flushing have resolved.
Okay, that's good. We're going to inspect and palpate her neck, front and back.
No abnormalities.
All right, and then we will uncover her chest so that we can inspect her chest and palpate her chest. Do I see or feel anything abnormal?
No abnormalities.
All right, and then I want to listen, and we're going to listen for heart sounds and breath sounds.
Breath sounds are very much improved. You do hear some scattered wheezes. Heart sounds are normal.
Okay, and then I'm going to look at her abdomen and flanks. Do I see anything abnormal?
No abnormalities.
All right, and then I am going to auscultate bowel sounds. Do I hear bowel sounds?
They are present, but they are hypoactive.
Okay, and then I'm going to palpate her abdomen and flanks. Do I feel anything abnormal?
No abnormalities.
Right, so now we are going to move to her pelvis and perineum. I'm going to inspect and palpate her pelvis and perineum, and we will consider if there's any contraindications to putting in a urinary catheter or consider another way of measuring urine output.
There's no abnormalities to the pelvis or the perineum. There's no contraindications to a Foley catheter, but diapers will be weighed, or an external urinary collection device can be used to monitor her urine output.
Okay, and then I'm going to palpate her legs. Do I feel anything abnormal? I will recheck her pedal pulses and recheck capillary refill, and we will do the same thing with her upper extremities. Again, inspecting and palpating both of her arms and reassessing her pulses and her capillary refill.
No abnormalities with palpation over all 4 extremities. Color, temperature, and pulses are all within normal limits.
Okay, now we are going to uncover her briefly so that we can inspect her back. Again, do I see or feel anything abnormal on her back?
No abnormalities.
All right, we're going to turn her back over and make sure we cover her up. And so back from the start, she came in with a cough, ended up being an anaphylactic reaction. We gave her 2 doses of intramuscular epinephrine. She's on an epinephrine infusion. We also found out that she was hypoglycemic, so we gave her some intravenous dextrose, which she responded to that, and she's on a ventilator. It sounds like her wheezing and her edema is improving.
Perfect. What interventions or diagnostics can you anticipate for this patient?
So we've given her only the epinephrine so far, which is the priority, but she will also receive nebulized albuterol if ordered, intravenous antihistamines or steroids as ordered. She will be on maintenance fluids with glucose so that she doesn't drop her glucose again. We'll get blood gases to evaluate her ventilation. She will need a chest x-ray to evaluate for endotracheal tube placement and gastric tube placement before transfer. And again, we need to look at any labs that we ordered and talk to whoever we're transferring her to.
Great. So all of those things mentioned will be ordered and instituted. What findings will you continue to reevaluate while the patient is in your care?
So we are going to keep an eye on her vital signs, frequent vital signs and trending of those vital signs. We will need to keep an eye on her breathing status, her glucose, so all of our identified issues and our interventions. Go back to our primary survey and reevaluate her pain.
Great. What is the definitive care for this patient?
She will need to be transferred to an intensive care unit and get followed up for this anaphylaxis thing.
She definitely will be. Is there anything you would like to add at this time?
No, I think we did as much as we could for her.
I think you did awesome. Thank you so much, Katrina.